But thank you so much to everyone who's here today for our webinar, Hepatitis C Treatment in Washington, Lummi Tribal Health Center, and Statewide HCV Elimination Plan. We'll be having presenters from the Washington Department of Health and from the Lummi Tribal Health Clinic. And I so appreciate their partnership in putting this webinar together and for all the great work that they do. So I'm just going to go over a few introduction and logistics, have Department of Health talk about the hepatitis C and HCV elimination in Washington. Lummi Tribal Health Center will present on their program, and then we'll have time for questions. So just a few webinar logistics. This is a Zoom webinar, not a Zoom meeting. What that means is you're muted and we can't see you. Only panelists and hosts can share their video and audio. Please enter any questions in the Q&A. They'll be answered at the end of the webinar, and enter any comments in the comment box. We do have live transcription enabled for anyone who needs it or likes it. You can turn it off either by going to the More and then hide transcription, or there may be a little CC on your bar that you can click and turn it off. The webinar will be recorded and posted here. We have a new webpage on Stop Overdose where our past webinars are and list of future webinars. So I'd like to begin by acknowledging that as we gather today, we are on the ancestral homelands of the indigenous peoples who have lived on these lands since time immemorial. Please join me in expressing our deepest respect and gratitude for our indigenous neighbors. So before we dive in, I have one slide I'd like to share, little context for this. First off, I'm very excited about this webinar because for 3 years, I was the hepatitis C coordinator for the state of Vermont. Hepatitis C is an issue I care a lot about, and that's very important to many of the communities we serve and the people we serve. And I just wanted to share one piece of data from our statewide syringe exchange survey, which this was last done in 2019. We're hoping, fingers crossed, we can do it again in fall 2021. We always ask people about hepatitis C, and this year we were able to ask if they'd been diagnosed and ever treated, and as well as interest in treatment. And we found that among people who were had hepatitis C and were not previously treated, that 68% were interested in treatment. So hopefully today you'll come away with some tools for helping to engage people who have hepatitis C in treatment, and a little bit more about hopefully how the state is making that easier to do. So I'm going to hand it off to my colleagues at the Department of Health. So excited to have Emily Hurio and John Stockton here today to talk about hepatitis C elimination and HCV in Washington. So thanks so much.
All right, good morning, everyone. John is going to take the sort of first part of what we had to say, and then talk about data around hepatitis C in Washington. And then I'll talk specifically about the work we're doing to address hepatitis C elimination in Washington. I'm going to hand it over to John, and then I will come back.
Can everybody hear me? I'm sorry.
Yep. I can hear you.
Okay, great. All right, great. Thanks. I was talking and all of a sudden it went away. So great. Let me so my name is John Stockton, the Adult Viral Hepatitis Prevention Coordinator here at the Washington State Department of Health, Office of Infectious Disease. And today I'll be going over just a brief overview of hepatitis C in Washington State, and go over some specifically some surveillance data as well. And we will be talking a little bit about the governor's directive related to Hep C elimination, and an overview of healthcare authorities' work, which is our state Medicaid program, and their work related to the actual directive. And then she'll be providing an overview of the Department of Health's work in coordinating Hep C-free Washington, which is our elimination efforts. So the first thing that I wanted to go over and just kind of help ground some folks in exactly what we'll be talking about today. This might be review for some, but just wanted to briefly go over this. But hepatitis really means inflammation of the liver. So when the liver is inflamed or damaged, its function can be affected. Many things can cause this, such as heavy alcohol use, toxins, some medications, certain medical conditions, all can cause hepatitis. However, really, for hepatitis is often caused by a virus, and that's what we'll be talking about today. People with hepatitis can be either asymptomatic, which is typically the case, or they can exhibit some symptoms, which can range from everything from a fever, fatigue, loss of appetite, abdominal pain, and joint pain. So the natural history of hepatitis C, when you take a look at this, is most people who acquire Hep C will develop chronic infection, meaning that they'll live with this for the rest of their life unless they receive curative treatment. Hep C is often thought of as causing liver disease, which it can, but it can also cause other things such as cirrhosis, which is scarring of the liver, and certain kinds of cancer. It is also a systemic disease that can cause problems outside the liver. So this can be things such as heart disease, kidney disease, and certain kind of cancer. When you take a look at the natural history, when somebody is infected with hepatitis C, they go through a phase called the acute phase, which during this time period, really only about 20 to 30% of individuals really actually have any symptoms. Typically, this is very asymptomatic. Many, however, will go into a chronic infection between 75 to 85%. From there, if folks do not receive curative treatment, absolutely it can cause other health conditions such as cirrhosis and other different types of cancer. So today we'll be talking specifically about hepatitis C. So there are other hepatitises. So especially within the United States, the most common ones are hepatitis A, which there is a vaccine for, hepatitis B, also there's a vaccine for. However, for hepatitis C, there is no vaccine for this. And it is also the most common bloodborne infection in the United States. We've seen over time, there's been a rising morbidity and mortality in the aging baby boomer cohort. So those ages are those born between 1945 and 1965. It's also one of the leading causes of liver cancer and leading indication for liver transplantation in the United States. Again, there's no vaccine for hepatitis C. I have to say that a couple times. Over my course of the career, I've done presentations for hepatitis C, and I remember at the very end of one presentation, somebody raised their hand and said, well, why don't you just focus all your prevention on vaccine? And I had forgotten to mention that. So I say that a couple times early on, just to make sure that folks know that there's no vaccine. Now, there's newer medications, which is really exciting for hepatitis C. There's direct-acting antivirals, or DEAs, that can actually cure infection of over 90%. And if you look at various studies, there's kind of a debate between over 90% and some say as high as 98% of patients in 8 to 12 weeks with very few side effects, so it's very well tolerated. And this is a big jump from previous treatment regimes, which was ribavirin and pegylated interferon, or interferon by itself, which folks did not react very well to. It had a lot of side effects, and your chance of any type of cure was very, very low. So new medications, which really has kind of changed the game when it comes to hepatitis C. So talking a little bit about surveillance, I wanted to go over what we see here within Washington. Unlike other health conditions and profiles, it's a bit tougher to accurately describe the morbidity of this disease within our state. And our state's not alone. You see this across the United States. But here in Washington, Hep C became mandated reportable condition in 2000. So the people that actually report cases can be anything from labs, healthcare providers, and healthcare facilities. Those reports then go to the local health jurisdictions. So in our state, there's 35 local health departments. Those go to the local health departments for investigation and disease control. And then that gets reported to the Washington State Department of Health. And then we report then to the CDC. So there's some challenges. So there's some limitations to keep in mind as I present some of the analysis that has been done in our state, which really include lack of resources at both, not just at the state, but also at the local level. At the local level, most local health jurisdiction staff work on all communicable diseases. So resources for hepatitis C surveillance are lacking. So inconsistent surveillance at the local level, especially when there weren't really good treatment options, and as such, Hep C investigations were not prioritized. And we have really don't have the resources to actively track patients who have moved out of state, died, cleared their infections, or have been treated and cured. So other limitations of surveillance, really the database registry include cases not captured due to reporting prior to 2000 when it became mandated, and the ability to conduct investigations are limited as a whole, especially for our current infections among people who inject drugs. So right now in our state, actually, well, within the United States, Hep C deaths exceed deaths from 60 other infectious diseases combined. So that includes things like hepatitis B and also HIV. Within our state, around 500 to 650 Hep C related deaths are reported in Washington each year. Since 2000, more than 15,000 people with Hep C have died in Washington. The median age in 2016 was 61. 47 in 2000, but 61 is still quite young. So in our state, what are we seeing? So one of the things that's really hard to answer is what is the prevalence rate within a particular state, given all the limitations. We partnered with CDA Foundation in 2019 to conduct an analysis. And at the beginning of 2018, what we found was there's an estimated 59,100 people living with Hep C in Washington. Counts, as you can see in the table to the right, have steadily increased over years. So from 2012, we had reported newly reported Hep C cases as 4,919. And as you can see there throughout the years, this has steadily increased. In 2017, 543 deaths attributed to chronic Hep C, and in 2018, 479 deaths attributed to chronic Hep C, and 118 new reports of acute infection, the highest that we've seen in over 20 years. Acute cases, much like chronic cases, we've seen a steadily increasing. So between 2008 and 2018, we've seen a 372% increase statewide. Of those, 75% of those who the risk factors when they were reported indicated injection drug use as the transmission. And we see the same thing with when we look at the chronic cases. So in 2017, we had the highest number of new case reports ever with 8,839. Not quite sure what happened with the dip in 2013, but as you can see, very much like the acute phase, we've seen a steady increase over time. Risk and exposure data for chronic cases is pretty sparse. We're looking at about 80% of those fields are missing. But when they're present, injection drug use is often indicated within the case report. So I stole this from the CDC. We use this often, but this is really just illustrating the direct correlation between hepatitis C cases and the opioid epidemic. Among people aged 18 to 29, Hep C increased by nearly 400% and admission for opioid injection by 622% over time. Among people aged 30 to 39, Hep C has increased by 325%. And emissions for opioid injection by 83%. So we can see that there's really a direct correlation between hepatitis C and the opioid epidemic. Now, there's different factors that may attribute to this as well. So this would include things such as, of course, increase in injection drug use, increase in screening and testing, reporting, perhaps, and also new screening recommendation, and just kind of a general awareness of hepatitis C. And what we're seeing in Washington is really kind of a tale of two epidemics that we're seeing. We're seeing a considerable shift in the demographics in the last 10 years. So this is a snapshot between 2007 and 2017. What we've seen is a noticeable shift in age distribution, indicating really kind of two epidemics that we're seeing within our state. That's the baby boomer age cohort and younger persons. In 2007, 69% of chronic cases were among the baby boomer age cohort. which represented and about 22% at that time were among people under the age of 40. Fast forward to 2017, we see a dip in the baby boomer age cohort at 52% and 31% increase among people who are under the age of 40. So we're seeing we're actually seeing two epidemics within our state. And this is continuing again in 2018, where we see very similar trends when it comes to demographics. So one thing about hepatitis C, so this is a snapshot of the care cascade within the United States. And so what this is showing is of those in the United States, 3.2 million people are thought to have chronic hepatitis C within the US. And what we're seeing is of those, only 50% actually have received an antibody test. From there, only about 38% of those who have tested antibody positive are actually linked to care. And of those, actually received Hep C RNA test of 23%, so that's the confirmatory test. From those who are RNA positive, only 11% in the United States are actually treated, and of those, only 6% have actually achieved sustained virologic response, which is essentially a cure. So that's of the United States. When taking a look at the state as a whole, looking at Washington State, we kind of see something similar, but there are some differences. So within Washington State, what we have seen through partnership with CBA Analytics is that, again, 59,100 people are thought to have hepatitis C within the state. Of those, 88% have actually been diagnosed. So we've been doing a pretty good job within the state of actually finding infection. Where we see the big drop off, though, is actually that linkage to care. So once somebody has been identified as having hepatitis C, we see that there's a huge dip into the number of individuals that are actually treated. Lots of different reasons for this. One of the hardest things to do is actually help folks navigate the healthcare system and actually link them to appropriate medical care. Of those who have been treated, we see that 7,000 or 95% of those individuals, when they are treated, are actually cured. And with that, I'm going to hand it off to Emily.
All right. Do I have the controls? I think I do. All right. So I'm Emily Hirio, and I work with John at DOH in the Office of Infectious Disease, and I manage our infectious disease prevention programs and our drug user health programs. So I'm going to just talk with our last, we have about 5 minutes for our piece around our elimination work. So Governor Inslee issued a directive in September of 2018 to eliminate the public health threat of hepatitis C by 2030. And we have historical activities that led to that moment. Advocates have been working in the hepatitis C space since the late 90s, demanding a state response to the virus. There was a strategic plan developed in the early 2000s and some funding in the mid 2000s. An update to that strategic plan in 2014, but really in 2018, in anticipation of the directive, there was a cross-agency work group of state entities that started discussing elimination. There's really two major elements to the directive. There's the piece Healthcare Authority has engaged in, which I'll talk briefly about, that was really looking at innovative approaches to purchasing the hepatitis C treatment medications. And then the part that our agency, Department of Health, worked on, which was bringing together community, everyone interested in the topic of Hep C elimination to develop a strategic plan. So as John mentioned, we have these DAAs that are highly effective. When they first came to market, they were extremely expensive, about $84,000 for a course of treatment. The costs have come down, but they're still, fairly pricey medications. these drugs are carved out of the Medicaid managed care contracts, which means that that healthcare authority actually purchases all direct acting antivirals for people living with Hep C who are covered by Medicaid. So with other treatments, the managed care plans may purchase their drugs themselves, but for hepatitis C, this is carved out. HCA purchases all the Hep C meds for all the managed care plans under the Medicaid rubric. And led an innovative approach to procuring these medications in order to expand access without increasing the state spend. And so I'm not going to get into the details of that agreement, but they ended up contracting with AbbVie Pharmaceutical for their medication Mavyret. And sort of simultaneous to that agreement, the Medicaid plan, Medicaid has removed any restrictions on treatment. So in Washington, if someone has Medicaid, there's no sobriety requirement. People can be actively using drugs and be treated. There's no evidence of fibrosis needed, so people do not have to have advanced disease to access treatment. Any licensed prescriber can screen and treat hepatitis C. They don't need to be a specialist. A provider doesn't need to wait to validate chronic infection. So if they get an RNA positive, they don't have to wait 6 months to get a second RNA test. They can treat whether the patient may be acute or not. And the really exciting thing is there's no prior authorization required for Mavyret, which should really simplify treatment access for people living with hepatitis C who have Medicaid. There's also, for people who for Mavyret is not a clinically appropriate treatment, they can still access the other DAAs on the market. It just does require a prior authorization. But we think for about 90% of people living with hepatitis C, Mavyret is clinically appropriate. So part of the work DOH did, and I'll talk very briefly about it, was bring together a group of folks who care about hepatitis C to create an elimination initiative. And that group is called Hep C Free Washington. And our mission is to work together to eliminate hepatitis C by 2030. And it includes community groups, local government, tribal government, state agencies, clinics, substance use treatment programs, really anyone and everyone that touches hepatitis C. We created some topic-specific work groups, and those work groups provided recommendations to the Hep C Free Washington Coordinating Committee. And those recommendations ended up in this plan, which was released in July of 2019. There's 15 goals and 90 recommendations under the goal areas. And there's a link to the plan here. And we looked at priority populations in the plan, places where we would want to focus resources. That really includes people who inject drugs, baby boomers, people who've experienced incarceration, people living with HIV, Native Americans, and African Americans. These are communities disproportionately impacted either by the virus itself or by the morbidity and mortality related to the virus. And we focused a lot on linkage to care in the plan because curing Hep C is both good for the individual, but it's also good for the community. If we cure someone who is living with hepatitis C and they're injecting drugs and potentially sharing equipment, this prevents them from transmitting the virus to others. Allison provided this information at the beginning, so I won't rehash it, but we know that people who inject drugs who are living with hepatitis C are very interested in treatment, but do not always get easy access to treatment. And so this is really, from a public health perspective, our #1 priority population for linkage to care. We have a lot of resources in the state that make us really suited to achieving elimination, including a long history of robust syringe service programs, really increasing and great access to medications for opioid use disorder, and a number of other assets that really make this possible. And then, of course, we have a number of challenges, and I think a main one is increasing homelessness and displacement. It's hard for people to prioritize getting Hep C treatment if they don't have a place to lay their head at night. I think this increase among young people with hepatitis C offers a particular challenge because these are often folks who are asymptomatic and don't feel sick. And so that's a place where if someone's struggling both with housing security, food security, they don't feel sick from hepatitis C, and they may feel stigmatized in medical settings, linkage to care, it creates some unique challenges. We also are really challenged with primary care providers who are not yet ready or willing to treat and cure hepatitis C in their practice. And we know that to eliminate hepatitis C, we really need Hep C treatment to live in the primary care space and not in the space of specialty care. And then just wanted to note, I think there's a lot of opportunity for collective impact and integration of hepatitis C services, as well as hepatitis A and B vaccination in places like mental health programs, primary care, sexual and reproductive health services, integrating overdose response with hepatitis C work, other infectious disease services. All of these things are tied together. And so there's a lot of opportunity in Washington to work collectively on what I call sort of the syndemics or braided epidemics that we're experiencing. I wanted to also add, I think, we have particular challenges around reaching communities that are disproportionately impacted, and we do really need to prioritize the communities that are experiencing the most harms related to hepatitis C and overdose. And then just lastly, I wanted to note that we have a new document we've created for healthcare providers about testing and treating people who use drugs for hepatitis C. So this summarizes the research on the topic, provides resources, and really encourages providers to be treating people who use drugs for hepatitis C. That's going to be a key key part of our strategy to achieve elimination. And that can be found at our website, which is doh.wa.gov/hepc. You can email us at hepcfreewa@doh.wa.gov. If you're interested in being part of Hep C Free Washington, we welcome you. Our meetings have been a little hit or miss lately because of COVID and people being really pressed for time and energy and bandwidth. But we do still have communications. Our community engagement work group continues to meet, and we welcome participation from folks who are interested. And that is all for us.
All right, so next up we'll have a presentation from Lummi about their wonderful, very comprehensive program. I've really enjoyed getting to know them and learning about their program. And it'll be Stephanie Ray, Michaela Hooper, and Emma Elsner. And if one of you wants to go ahead and control the screen, you can start your presentation. And yeah, once again, just want to say thanks so much for work DOH is doing and for Lummi for agreeing to participate. And we'll have a little time for questions at the end. And if you want to put them in the chat, even if we don't get to them now, we'll make sure to answer them in the future.
All right, and everyone hear me all right?
Yeah, I can hear you.
Okay, great. Thank you for that introduction, Allison. Good morning, everyone. I'm not sure if my camera is on. I hope so. I tried to open that up. Okay, well, good morning. My name is Stephanie Ray.
My name is Michaela Hooper, and I'm Emma Elsner.
And we all work in the Harm Reduction and Hepatitis C project office here at the Lummi Tribal Health Center. So I just wanted to take a moment to introduce Emma Elsner. She is a very recent new hire to our program here, and we're really excited to have her on board. So we're really honored to be a part of today's talk on hepatitis C elimination and just share a little bit more about what we do here out on the Lummi Nation Reservation. Can you do this?
Sorry, just figuring out how to control the screen over here. So our Hep C and harm reduction office is located within the Lummi Tribal Health Center, which is a primary care clinic here in Bellingham in the northwest corner of Washington. The health center was established in 1978. We now serve close to about 6,500 patients, all of whom are American Indian or Alaska Native. Within our area of Whatcom County specifically, American Indian and Alaska Natives account for about 3% of the total population. And our harm reduction office is located inside of the primary care clinic here. And Stephanie's going to talk a little bit about the origins of the Hep C prevention program specifically.
Okay, so before diving into our history, I just wanted to mention that on a nationwide scale, the American Indian and Alaska Native communities are disproportionately impacted by the opioid epidemic, with the second highest opioid-related overdose death rates compared to other ethnic groups. So that being said, back in 2012, it was discovered that about 40% of new hepatitis C cases in Whatcom County were Alaska Native American Indian identified individuals. So this illuminated a very urgent health disparity that needed to be addressed right away. So in an effort to prevent and decrease the transmission of bloodborne infections and work to lower the risk of opioid overdose, a needle exchange program was founded by several clinic employees back in 2013. So our harm reduction program was born out of those initiatives to treat hepatitis C. Providing clean syringes to community members who inject drugs was a crucial step forward in fighting the fight against hepatitis C. That being said, there were certainly growing pains and concerns around privacy for people accessing services back in 2013. Patients used to access supplies via nurses and doctors during or after their routine doctor's visits, but there was no specific staff dedicated to hepatitis C and harm reduction work. So as our program grew, it was revamped in 2015, taking into consideration the input from community members who had been accessing the service. And slowly since then, it's gained a lot of momentum over the years. Now our clients and patients can come directly to our office, and this has really helped mitigate a lot of the stigma surrounding substance use.
So going into a little bit of the Hep C specifics that Stephanie and I coordinate here in our office, I think something that's very cool about our harm reduction program here is that we are simultaneous the Hep C case coordinators, and we are the harm reduction program. And that's great because there's so much overlap between those two population groups. So often someone will come in initially just for a harm reduction visit, and through that visit with them and just, going through their history, health history, we'll encourage them, to get a screening done here in our office. And then because we're located right here within the primary care clinic, we can just transfer them over to the Hep C side of things and then follow them through their treatment all the way, from that first antibody test they do all the way, hopefully, to getting their SVR12 labs done at the end of their treatment. So we offer Hep C treatment to all of our patients, including those who are actively or intermittently still using or injecting substances. Treatment for the Hep C is done through our primary care providers. So Stephanie and I work very closely. I think that we have 3 or 4 providers here right now who prescribe Mavorite and are
the number is growing.
Yeah,
definitely.
Yeah, it's increasing. Who treat Hep C. And there's an image here on the left of this slide that I just wanted to focus on. This is an image that we use very frequently here in our office. It's focusing on the spectrum of harm reduction, specifically as it relates to treating Hep C. So we focus on assisting our patients through interviewing them on their readiness for change. And when I say interview, I don't mean like a strict sit down interview. That's kind of I don't know if you've heard of motivational interviewing, but that's a practice that Stephanie and I try to use where it's very patient centered model. Recognizing that Stephanie and I cannot get anyone to change their behavior if they are not willing or ready to. And so meeting them where they're at and working with them to help achieve their harm reduction goals, whether that be just, emphasizing safe injection practices for now, or helping them treat their hepatitis C if that's what they're ready for, or if someone comes in is wanting to start treatment, or medication assisted treatment is something we offer out of our clinic here. So that's another thing that we help people access depending on where they are at. And just a little note, a barrier that we've been facing in light of COVID-19, we no longer have participants who are wanting to access the harm reduction program. They used to just come inside, sit down with us in our little office here, kind of just like a regular routine visit, and chat with us. We have a bajillion different pamphlets and flyers, depending on what they're needing at that time, and a plethora of different supplies, and we'd have a conversation with them, get to know them that way. And now we, and for Hep C, that was great, because when they're sitting in our office, if we are discussing infectious disease prevention and mention that we're able to screen them right then and there, often that's where that first antibody test would happen, just here in our office. But now we are meeting with participants outside in the parking lot. Stephanie and I sometimes call it the drive-through harm reduction model. Yes. And that makes it a lot more difficult for participants to feel comfortable having longer conversations with us and going through their medical history, as often there's other people around. Often people show up in groups too, because many of our folks don't have consistent access to transportation, so they'll hitch a ride with other people, and that's not the best environment to be going into someone's health history with them. Right. So it's just to note that COVID-19 for us has posed a pretty significant barrier that we are honestly still working on how to overcome.
Yeah. Okay, this here is a pretty detailed flow chart of what our hepatitis C care looks like here in our office. As you can see, our patients come in with either a known antibody positive test or without that, or already a positive viral load. And so we use this flow chart to really take our patients through the steps of, getting all of those baseline labs, the initial fibro scan, which either Michaela and I do, or one of our radiologist technicians. And then from there, getting the patient to sit down with a provider, begin treatment, and so on and so forth until their last labs and best case, their cure of hepatitis C. And so would be more than happy to talk a little bit more about this flow chart later.
Something I want to point out here is that we really do try and get as much done for a patient on the same day that they present to the clinic for our harm reduction program, because I already mentioned the transportation barrier, but access to a phone or to consistent way to contact patients, that's also another big barrier that we run into. So when someone is here sitting in front of us and says, hey, yeah, I want to start Hep C treatment, we want to get as much done for them right then as we can. So that's why having the FibroScan machine here at the clinic is so incredible, because we can just bring someone down to that room and scan them there.
Send them to the lab.
Yeah, the lab is also right here in the clinic, so we can just send them down the hall to get that done as well. Really, we'll just have to wait for them to come back to actually start the medication.
Yeah, that was definitely what Michaela just mentioned, was definitely one of the beauties of our harm reduction office pre-COVID-19, because we could just get steps 1 through 5 completed in that first visit. The antibody screen, send them to the lab for the initial viral load and the other baseline labs, then the fibro scan, and hopefully schedule them for their initial appointment with a provider could all be done in that same day, same time.
Yeah, some of our providers even, or one I know for sure, has a time blocked off on their schedule every day. That's an hour long that they reserve for harm reduction patients so that we can do last minute scheduling that same day for them.
So our next slide is a little bit about our current program. Nowadays, our office is known locally as the exchange office. The syringe service program is open to anyone, as Michaela mentioned, both tribal and non-tribal folks alike. So typically, pre-COVID-19, a client would come to our office or come to the clinic and call our harm reduction office number. We'd call them back to our office, and we'd just start off by asking them, how can we help you? And let the client really guide the interaction by explaining what they think would be the most helpful. Again, really focusing on that patient-centered interaction. And staffing and hours, we're open every day of the week, Monday through Friday from 8:30 until 5. So the regular clinic hours. Again, we're located within the primary care clinic, so we're just our own little entity inside the clinic here. And then in terms of the services provided, we have a list here of all the things we have. Let's see. So hepatitis antibody testing, that screening, that initial screening, as well as testing, naloxone education, care coordination to other places, medical care, of course, vaccinations, referrals to other places. We offer a wide range of services open to anyone in the community, both tribal or non-tribal. And with that, we offer clean injection supplies, including syringes of different gauge sizes, cookers, wound care, sterile straws, fentanyl testing strips, Narcan, and just a plethora of educational materials and other stuff. So as well as all these harm reduction supplies that we offer, we are very huge advocates of safe disposal of sharps and substance use materials. So this slide here depicts one of our 4 large disposal kiosks. So we have 4 of these located throughout the reservation, including this one, which is outside of our clinic parking lot. And the harm reduction teams, and Michaela and I, typically clean these out once every 2 weeks or so. And we estimate that a full kiosk will hold up to between 5,000 and 6,000 syringes.
We also go out into the community to different properties where syringes have been found and do pick up ourselves. So we have a cell phone that is the syringe safe disposal hotline that community members can call, and we will come out. We obviously, Stephanie and I are fully trained in proper disposal of sharps, biohazard trained as well. So we'll come out and help dispose of them. And I think this has been a really cool initiative we've started to help kind of improve our relationship with the community and put a good, help people understand what we do here in the harm reduction office, because often once we go out to someone's or out to wherever the report has been made, we'll meet the person who found them and kind of get to talk to them about what harm reduction is and what we do here. And so that's been something, and this is a new initiative kind of as of the last year. And so here's just a few pictures of kind of the places that we're going and where we're the syringes that we're finding. And
so oftentimes we'll go out to a beach and clean up syringes from there. These are all sharps containers that we bring out to different sites to clean up. And I think this new duty has also helped mitigate some of the tension between our program and the Lummi Council, as well as law enforcement, because it's just an extra hand really in helping to keep our community safe and help educate people more on this harm reduction philosophy.
Yeah, so here are a few graphs that just show the incredible increase in syringe service program participation we've had since that program began all the way back in 2013. Like we said, it wasn't its own really specific program. It would just be a few nurses or providers who would provide the supplies on request. So just for some numbers for you to hear, in 2019, we had about 518 visits. At the end of 2019, we had about 1,200 visits. So we'd almost doubled that. In 2019, we gave out an estimated 100,000 syringes. And as of the end of 2020, this year we'd had done about 350,000, excuse me. So our program really is growing. And of course we're so happy to see that. And that does come with a couple, some barriers and growing pains as we figure out how to meet the new demand. Obviously we are trying to increase our funding, getting more of the budget allocated to the harm reduction program. All of those are things that we're working on with our supervisors.
Okay, so harm reduction in the time of COVID-19. So I'm sure everyone can imagine and relate to, running a syringe service, a harm reduction office looks vastly different in the time of COVID-19. We used to meet people within our office, like I mentioned earlier, where Emma, Michaela, and I are currently sitting. However, due to the pandemic, people aren't allowed into the clinic anymore. So our office has transitioned to connecting with individuals either outside the clinic, outside the front door, or over the phone, or through the clinic van, which is in the lower right-hand corner. This van was purchased at the beginning of 2020, and it has multiple roles, including operating as a mobile syringe exchange unit. We've set up the van in our clinic parking lot when the weather permits and ask people to meet us outside the van around the back of the clinic. We stock it with all the supplies that we carry in our office, including the kits that we make, the syringes of different gauge sizes, Narcan, fentanyl test strips, and all the educational brochures. So we found that using this van offers our clients more privacy and the opportunity to connect with them in a bit safer environment while still complying to the social distancing measures. And since COVID-19, we've also been ramping up our community outreach services. We're noticing a lot more people are calling in to our harm reduction cell phone and asking for supplies and pickup of used materials. So we've been using the van to do all of this community outreach.
Yeah.
There are also a couple other things I wanted to mention that are new to, since COVID-19. In the upper left-hand corner is our shower trailer, which is open every day of the week from 12 to 3 o'clock, and our laundry trailer, which is open the same hours. And these are available to anyone and everyone and for free of charge. And so this has been a really neat addition to our program as well.
Yeah. And with this, the van has just been such an amazing resource for us to use. Stephanie and I will take it out. We'll have one person call in and say, hey, could you bring me some supplies? And we'll go out to visit them. And on our way there, people kind of see the van, they'll flag us down, and we end up, conducting like 10 visits. And it also, once, like Stephanie said, when the weather permits, this is a great way for us to still be doing the Hep C screening because it's outside. And people are not, they're often coming alone. They're not around as many people. It's a little bit more discreet.
Right. And when we set it up behind the clinic, we can pull out the awning and have maybe a chair out, keep everyone 6 feet apart, and just have a little bit more private space to really get to talk with people more instead of just, crouching down at their car window and talking to them about these stigmatized topics. And so it's really great. We're looking forward to the spring. Thank you.
Yeah.
So to piggyback off the new clinic van, our team has also started a program at the beginning of COVID-19 in early April of 2020 when we observed a spike in our opioid overdose numbers on the Lummi reservation. This spike really prompted us to implement a pilot program, which has served to highlight many of the barriers faced when trying to access care. So our mission in this program has been to offer a low threshold point of access to harm reduction info to high-risk patients who have been difficult to reach through our fixed location here at the clinic. So it's been a big effort, including staff from not only the clinic, but also the Lummi Behavioral Health. And we have since realized that it's a really good way to distribute more harm reduction supplies and education and bring more support to social circles of other social circles. So it's expanded our network and helped us reach new people in our community. We started out by hiring about 5 community members, 5 peers from the Lummi community. We call them our harm reduction contractors. And we're currently in the process of completing our 4th cycle. Each cycle has about 10 trainings. And we meet with anywhere between 10 to 15 community members once a week for 1 hour via Zoom to discuss a very wide range of topics, including harm reduction philosophy, overdose prevention, recognition and response, safer injection practices, infectious disease control, referral to care elsewhere, medication, nutrition and wellness. And we even had a representative from our dental clinic come by and talk about oral hygiene. So sometimes, it's Michaela and I presenting at these talks. Other times, different healthcare workers will join us and help facilitate these trainings. And it's great. It's a great opportunity to, nurture these relationships that we have with community members and learn more about what works and what doesn't.
Yeah. And Stephanie and I, we recognize that we're not the experts, right? And what we want to be meeting the needs of the community, and we can't do that without knowing what they need and knowing if the information we're providing is even helpful or not, right? So I think that this training we do is kind of how we, keep a pulse on the community and make sure that we're giving the community what it needs and providing resources that are actually helpful. Yeah, and like Stephanie said, it's just really massively increased our network. And I think it's part of why we've seen such an increase in numbers, is because more and more people are hearing about what we do. The training is also, I don't know if you mentioned this, Stephanie, but it's paid. Right, I think that's a really important part as well. So they receive $100 per training. And that was, approved through Lummi Council, as they see this as a really important initiative, both, in treating hepatitis C and other infectious diseases, and in particular opioid overdose, and making sure that everyone knows how to use Narcan, how to recognize an overdose, and how to properly respond to it.
Right. So in this program, we really try to emphasize the flexibility and the customization that comes with harm reduction practices. And we believe that participating in our program, it's not an all or nothing activity. So we try to give our community participants access to all the resources we have available. And ultimately, we learn from them, because we believe, as Michaela mentioned too, that after all, they are the experts. And so we're trying to learn from them how to best serve them and the community.
And one more cool aspect about this community-based program is that we've been able to start a few what we call satellite SSPs for different, people who have been coming to the trainings for a couple months now, and they will come to us and receive, quite a large amount of syringes that they'll keep at their home to distribute to other people. And they'll hand out some of our pamphlets and flyers, give out Stephanie and I's phone number, and kind of just spread the word about what is available at the harm reduction office. And so that's been something that's I think is so cool and really expanded our network, and it makes me feel like it's working.
Right. So initially, when we started the program, the harm reduction staff, we identified a couple potential peer contractors that we knew just based on weekly interactions, that we knew were individuals in the community who were trusted by people who use drugs. And so as the program has grown, these peer contractors have actually begun to suggest new peer contractors for hire as well. And so now when we meet with a potential new hire, we explain to them the program and the position, and sort of figure out if they're interested in participating. Then we have them complete a W-9 form, have them sign a position description paper, which is theirs to keep. And then an invoice is submitted every week, and the peer contractors are paid, like Michaela mentioned, $100 the 2 Fridays after their date of participation.
One significant barrier, obviously, here is the fact that these trainings have to take place over Zoom in light of COVID. And as you've mentioned multiple times, having access to a computer or phone is not,
Wi-Fi.
And Wi-Fi is not something that many of our participants have. At the very beginning of this program, back in March or April, there was a grant from, I think from HCA, I'm not sure, but we were able to get some cell phones that we could loan out to folks. And we have like 2 iPads we can use. People can pull up in their car, and we'll bring the iPad out to them, and they can attend that way. Right. But that still is a barrier that at this time we're not really sure what we can do about, as long as COVID is happening and we have to maintain social distancing. So hopefully that's something that will change in the future.
Okay.
So
I guess we'll open the floor out now for any questions.
That's what we have for you. Thank you for having us.
So does anyone have any questions that they want to put into the chat? I just want to say thanks so much to our DOH colleagues and Lummi for doing this presentation. I learned so much and really appreciate hearing the higher level information and then hearing what that can look like in practice. So you can either enter questions in the chat or the comments if you have any. Is there a link for the quick reference sheet for primary providers that we can use?
I will put it in the chat.
Great.
And I just wanted to add that a lot of the work Lummi has done has been an inspiration for the statewide elimination work. It's just always impressive to hear you all talk about how you put all the things together in one place, one-stop shop for folks. It's inspiring.
Thank you.
Yeah, I agree. I have one comment. Thank you so much for this presentation. It was so informative. So, and I see what's training link. Is that a question or a, could you clarify that question a little bit? And if there are any other questions, feel free to put them in comments or the questions. Yeah, it was Saley Riho. I'm just not sure what your question was, and I want to make sure we get it answered. So, any other questions for Lummi or for DOH? I also want to say just thanks to Hepatitis Education Project for everything that they do around Hep C and all the viral hepatitis in our state. I know a lot of you, or several of you, look like you're on the webinar, so thanks for participating. I see a comment. I'm so impressed and inspired by Lummi's comprehensive program. Thank you to DOH and Lummi for this webinar. Very nice feedback. I don't have any specific questions, but just love hearing about the harm reduction program. Oh, the training mentioned. Is there a link to register? Okay. If there is someone has it. When will this webinar be posted to rewatch and share? I'll be posting it on our Stop Overdose webpage next week, just once we have the recording process. I'll put the link in here. It also will send out an email to everyone who attended and signed up so that they know it's available.
Hey, so I'm also wondering, that question asked about the training mentioned, is this referring to the training Stephanie and I discussed, or is there another training that question is about? For Sally Riho? Is that the Lummi training?
Well, oh yes, the Lummi training.
Okay, so that training is, we'd be more than happy to meet with you or talk with you on a phone call. Our contact information, Allison will, I'm sure it'll get posted somewhere. The training is only for Lummi community members. So if you were wanting to just get an idea of what they're like, we'd be more than happy to talk with you about that. But at this time, it's just for the Lummi community to attend.
And we do send out to our peer contractors, we do send out a link to the Zoom meeting, which they select and join our meeting every Tuesdays now at 11. So we do text out those links every week.
That's great. Any other questions that people have or comments that they want to share? All right, well, it's 10:59, so we can give you 1 minute back of your day. Oh, thank you. I'm part of the board, Dominican Association of Seattle. Please email. Okay. That is from Siley Riho, so perfect. You all can connect. But thank you so much for everyone who attended today. Thank you for our wonderful panelists. Really excited to see how much things have changed since I was the Hep C coordinator for Vermont. So have a great day, everyone. Really appreciate this. Thank you.